Yeah, just clear it a bit.
Yeah, I'm just gonna sit here. You gonna sit there?
My life on it, so I don't want to forget it. I think we're all set then. So it's been a while since we've had an FE hour, so thanks to everyone who has come today, and a special thanks to Dr. Moore for agreeing to give the first FE hour of the new year. And so I want to just run through a little short introduction, and then I'll turn her presentation on Hep A over so you can hear all about that. So I did want to let everyone know that Dr. Moyer actually received her Bachelor of Arts degree in physics from the Colorado College. Are you actually from Colorado?
I'm not. I grew up in Chicago area.
Okay.
Colorado for college.
So anyway, after Colorado, she went and received her Master of Public Health degree from Dartmouth College, and then her medical degree from Temple University, and then she completed a family medicine residency at Wake Forest School of Medicine. And then she came to Louisville, Kentucky, to our great benefit, and she's now the director of the Louisville Metro Department of Public Health, where she's been really deeply involved with the communities of our city, and actually was responsible for opening the state's first syringe exchange program here in Kentucky, and opening up a separate office on addiction, and has made quite an impact in that regard. And additionally, she is a professor, an assistant professor within the School of Medicine, and she also holds an appointment, as you all know, here in our own school in Health Management System Sciences. And with that being said, she's going to talk about her experience with the Hep A outbreak.
So yeah, thank you for that. Do I need to press record? Is it for your? All right. So, who here knows we're in a hepatitis A outbreak? Everyone? People have it. So, just for general situation awareness before I dive into hepatitis A, we've had, at this time, as of today, we have 60 cases of acute Hep A since August is when the start of our outbreak. Usually in Louisville, we have 1 to 2 cases a year, and so this has been a huge increase that the state health department declared an outbreak at the end of November when we were at 30 cases, because we were able to genetically tie it back to the outbreak that was going on in California, and also connected to Utah and Michigan. So we have been in full force trying to stop the spread of this since about November, when we started our incident command system over at the health department to really try to get ahead of the outbreak. So today just going to go over the cases, the at-risk population, and then just some lessons learned and how we could maybe even use your guys' help moving forward, because we are still in the middle of this outbreak. So what is Hep A? So hepatitis A, it's a viral infection that affects the liver. You get fever, fatigue, headache, body ache, but the big thing is you turn jaundice, or like a yellow color, and so that's one of the defining characteristics. And also we look for, in the labs that we get back, a really big increase in the liver enzyme, so the AST and ALT. It's transmitted by the fecal-oral route. This is different than hepatitis B and C, which is blood-borne, and so because of this, it's from direct physical contact. B and C, which is what we've been dealing with in the people who use drugs population for the last few years, most have just been in the injection drug using population. But Hep A is is because it's the fecal oral and not proper hand washing, we're finding to be in a greater population, and also really affecting our homeless population, which has less access to hand washing and general cleanliness, bathrooms, etc. There is a vaccine that's available. It's very, very effective. Just one dose gives you over 93% effectiveness. There's also a vaccine that does B and A together, and that one gives you about 90% effectiveness just with one vaccine, and it's really close to 100 if you get 2 6 months apart. And so we have a really good preventative measure or cure, and so that's what we're focusing on with this outbreak. Hand washing is still the most effective preventative tool because you wash off the fecal matter and you won't get hepatitis. And just for your information, the hand sanitizer does not work for hepatitis A, and so we're really been pushing actual hand washing with soap and water to get the virus off hands. So the CDC, before even this outbreak, and we've been having hepatitis, they recommend that all kids get vaccinated. So the state law actually just changed in Kentucky that all kids, school-age children, are going to have 2 hepatitis A shots to go back to school by next summer. And so there's been a huge campaign to start pushing that. Now most pediatricians have been giving it for a lot of years. I think the American Academy of Pediatrics has been recommending it for at least 10 years. So most kids already have it, but it's new to be on Kentucky's immunization registry requirement. And they also recommend that anyone, the high-risk populations before this outbreak were MSM, people who use illicit drugs, traveling to countries with a high rate of hepatitis A, if you have any chronic health conditions that put you at high risk of having worse outcomes if you get hepatitis A, so like long-term liver disease, if you have cirrhosis, or hepatitis B or C or something that already affects your liver, getting this could be more harmful than healthy people. And those who get blood-borne products that help a blood clotting disorder, and those people who work in hepatitis A research. So that's the general recommendations. That's who we've always been trying to push to get Hep A, but this is new. So hepatitis A across the U.S., we are not the only city experiencing an outbreak. California was the first, probably seen that in the news. They've had close to 700 cases now and 21 deaths from hepatitis. And they're mostly in the homeless and people who use drugs population as well. They've been doing a lot of vaccination efforts in their homeless camps. Michigan, same thing. They've had a big outbreak in one of their jail populations. Their death rate is is about the same as California. And then Utah, which has a similar kind of demographic to Louisville, their outbreak started in about May, and they're at 146 cases now with 0 deaths. And we are at 60 with 45 hospitalizations and 0 deaths so far. And this is since August is when we first started seeing the increase. So this is outbreak. So our EPI's put together this really cool map that shows just time related where our cases are, have been by like months and how they've popped up across the city. So it's pretty widespread across the whole county. Majority, though, when we were trying to figure out who it was really affecting, we did maps and cases to trying to link it anywhere. So initially our first cases were like really sporadic. We couldn't really figure out any connection. But we're able to link it to like LMPD violations, and then we started getting more back about illicit drug use in some of our cases. And so the 2 biggest groups that we're looking at now are homeless and people connected to the homeless, and then also people who use drugs. And it's not the injection part of it. Again, it's the sharing, the unsanitariness of sharing supplies and hand washing, etc. Alright, so when we get a report back from the hospital that we have a case, we have made a quick sheet that we're trying to get anyone who is suspecting hepatitis in a patient in the ER because initially we were having a hard time that the ERs would be doing labs, and then the patient would either leave against medical advice or be okay and go home. But since it was a very high, a vulnerable population, we had a really hard time trying to follow up on these cases to get more information, so we could build like an epi link. So we've started, anyone that they're suspecting now of having hepatitis, we're trying to encourage them to fill out this form so we can get a better sense of who they are, who they're connected with, how can we stop the spread of the disease. And so it's been really helpful to try to get some of this information back earlier. And so we're asking all the suspected cases if they've stayed in shelters or they stayed in the street, if they've been in jail or prison recently, any family members or friends that you've had contact with. Because the other great thing about hepatitis, as opposed to other diseases, if we can get them vaccinated 2 weeks after being exposed, majority of the time we can prevent them from having hepatitis. And so the quicker we can get this information back and follow up on contacts and get them vaccinated, we can stop the spread as well too. And so having this form in the ER has been really helpful to try to get the information before we have the confirmation in the labs actually back. So because of that great detective work from our team, the groups that we're really trying to target are, one, people with chronic liver disease, because we know from the deaths in California and Michigan, these are the people that are at the highest risk of mortality from hepatitis. And so that's our number one that we're really trying to get vaccinated. Unfortunately, most people with chronic liver disease also have other occurring factors, usually alcohol abuse, other drug use, and so it goes really hand in hand with our homeless and people who use drugs population. So people who use drugs are our next at-risk group in our target population. We're trying to reach with vaccination. And like I said, it's not a bloodborne pathogen, so it's not the injecting that we're really trying to target. It's just the actual sharing that we're trying to target. And trying to increase hand washing with soap and water, not just hand sanitizer. And then people who are homeless or those in unstable housing has been the other biggest risk factor. And we think a lot of this has to do with the lack of access to hand washing and restrooms, gathering together in close places like shelters or camps or where they're staying. And they already tend to have worse health than the general population. So we stood up our incident command structure in November when we reached about 19 cases. We really wanted to, based on the experiences in California and Michigan, wanted to have a really strong initial response to prevent a lot of the deaths and hopefully prevent the outbreak from really, really spreading. It's been really helpful to have our emergency preparedness team involved in really trying to plan out our vaccination priority list and getting additional staff in the health department trained and trying to figure out other resources we can use to really try to get our at-risk groups vaccinated. Also using our communications team to get easy-to-read communication materials developed. So that's our command structure. You can't read it, but so I'm in the incident command position. I don't know if you guys have seen ICS training. We have an operations chief, a planning chief, and then a logistics and finance chief. We combined those two roles in this because the finances wasn't a huge part, so we combined the logistics and finances. We have deputies for each of those. There's a medical officer or a safety officer, and then each of the vaccination sites we assign site leaders to them as we expand our vaccination efforts. So the priorities of the incident command are, one, safety and security of our personnel and our volunteers. We really want to prevent the transmission of Hep A, especially to the underserved populations. Really want to try to reduce some of these disparities that we're seeing in this Hepatitis A outbreak. And then just build knowledge in the community about hepatitis. Initially, we were meeting every single morning for an hour or two, just trying to get the plans off the ground, and it's the 7th of November. So next week, we've been able to scale back the actual planning. That's the top, the blue part, to just twice a week, and we have phone calls to check in between that. So the big sites that we're vaccinating right now is our syringe exchange, because that's the easiest access we have to some of our high-risk groups. And so getting everyone who comes into the syringe exchange vaccinated, and we're doing that through our TB clinic, which is right next to the syringe exchange. Family Health Centers Phoenix is a federally qualified health center that just serves the homeless. There is about 6,000 to 7,000 homeless in the city, and this clinic has contact with about 6,000 of them. And so we've been sending a team out there every day since November, vaccinating their population, and it's been a great way to connect with the population because they already have that relationship with those providers. And so that's one of the lessons what we learned from California was that you really got to tie into groups that already exist in order to have that trust with them, because they usually tend to be a little bit more tentative about government coming in and saying you need to do this. But if you find people that already have that relationship and going with them, it's been really successful for us. So that one's been the most successful. And then we've started vaccinating with our other syringe exchange sites. We have teams going out every day to different shelters across the city. So this week we went to VOA and going out to Healing Place tomorrow. But we just planned out that we're going to be going to one, and then based on our planning priority list that we're contacting based on the number of people they have, the number of turnover, is how we're trying to pick which shelters we're going out to first. It's mostly shelters and then also treatment facilities. And so trying to pick the ones that have high turnover, because those are the people that we're expecting to relapse, unfortunately. But that's the population we're trying to reach. Our methadone clinic is more. Specialty clinic is our STD clinic. They see a good number of MSM in that clinic. So MSM is a traditional risk factor for hepatitis across the world right now. In the U.S., it's a different strain than the one that's going on in the homeless and people use drugs population, and so we've had a few MSM in our epi, but not the, I guess a bunch of the slides didn't show up, but not the numbers that, all our MSM that have come up in our epi list have also been either homeless or illicit drug using. So it's not like its own separate risk factor that's co-occurring risk factors. But we've been able to transfer vaccine to them to try to target that, and we're keeping a close eye on it, and if we need to build that out, we plan to. So street outreach, Louisville's got a great homeless coalition that does a lot of street outreach to the homeless, and so we've had teams tap along with them doing giving vaccinations to the camps. So this is the numbers we've done so far. Corrections is the other big one. We were able to set them up as their own separate site, and so now we're transferring vaccine to them and using their nurses to give vaccinations. And started with their staff to get buy-in, and then their staff are now giving the vaccination to the corrections. So 85% of people in corrections are in our high-risk groups. They either have risk factors of homelessness or drug use, and so that's a great way for us to reach them somehow besides trying to find them on the streets. Our syringe exchange is given about 600 vaccinations in the last 2 months. Family Health Center Phoenix, about 500. Our methadone clinic, especially to see the numbers, and then some of the shelters that we've reached already. So we've given about 1,500 vaccinations to our really high-risk staff, and then have been using our partners with primary care providers and the pharmacies and U of L to give to people that are connected with these high-risk groups. So all of our staff, other Metro government staff, Centerstone staff, we've been partnering with Kroger and Walgreens to get their staff vaccinated that have that work closely with our at-risk population. So 1,500 seems like a lot to me because it's been 2 months worth of work, but we've calculated that our goal really is going to be about 24,000 vaccinations. We really want to get everyone. Looking at the National Survey on Drug Use and Health, there's about 3.5% of the population in Louisville are illicit drug users, and so using that plus all the MSM and homeless, we get to about 24,000. And then on top of that, trying to prioritize all the contacts of our high-risk groups and food handlers, and then really trying to push the new state requirement to get all kids vaccinated. And we continue to collect more data. So Sunday street outreach, the team gave 5 vaccinations, which doesn't sound like much, but they encountered 30 individuals in 2 different camps, and were able to vaccinate 5 of them that day. 4 of them out of the 30 that they reached declined, and 17 had said they had already been vaccinated. And so, to me, that's pretty good for a population that is really tentative about government services. But they are really high risk, so out of that 34 of them knew someone who had hepatitis A as well too. So yeah, just collecting data on our priority list and working through this and trying to just vaccinate all our high risk. And then, so there's a ton of slides that didn't show up in here. I don't know. Yeah, I don't know enough about PowerPoint to know why some of the slides have dashes through and didn't show up in the presentation.
They're hidden. Yeah.
They're hidden. Okay.
Yeah.
Just right click over, right click.
All right. Well, thanks.
There it is. The last one.
The last one.
Yeah.
Oh, right. Oh, I
Highlight on. Sorry. So, this, I was like, where's my epi curve? So, there it is. So that's our cases kind of since August of when they've shown up. Whoa. It was awesome fast. Yeah, so that's the outbreak timeline. So just a few cases were trickling in. Our epi was like, hey, I think we're seeing like a few more cases of Hep A than normal. Like, we usually always see 1 to 2, and we're at like 4 right now. It's like, okay, let's keep a close eye on it. And then they slowly started trickling in more, and then we were able to get a couple of the people identified to come back to get extra labs drawn, and then those are the labs we sent to the CDC to link it to the outbreak in California. And so we're able to declare an outbreak quicker than we would have just based on numbers, which was really helpful because that allowed us to get extra support from the CDC. So they're sending all of their we're getting 317 vaccine, kind of for free. The state has a line item to purchase vaccine in outbreak cases, and so since we were able to declare an outbreak, they're able to use that money to purchase the vaccine from the CDC, and we've been able to use it at no cost to the health department. A lot of their costs for other things, but we're getting the vaccine for free. Because of that, there's a lot of really, really strict requirements that go along with it. It's the same requirements as the Vaccine for Children's program, so you have to have specific refrigerators, and you have to have certain training, and that has really decreased our ability to respond quickly. So it's just been, that's one of the lessons learned, just trying to balance that rule following with the quick response, and how do you bridge that to prevent an outbreak in your city. But that's our epi curve. Cases are still coming in. I'm hopeful that they've trended down and are going to stay down, but because of the way the labs come back and get reported every day, like Monday this week, we got reports of 5 new cases that kind of were spread out over the entire time. So that, some of them are all the way back to October that we just found out about. So it's hard to know, so we're still responding that it's still increasing. So case characteristics, sorry, this is totally out of order. 40% are male, or 66% are male, 33% female, and interesting enough, this is about the exact same percentage of the data looking at our syringe exchange program, and so it just really ties back to that illicit drug use. Average age is 38, no deaths,
we're up to 45 hospitalizations now. And that CDC confirmed number is the number that we were able to get extra blood work sent to the CDC to actually do the genetic code of the virus. So these are all the risk factors that we asked for on that sheet that you saw earlier. Contacts, 9 of the cases, 9 out of the 60 were contacts to other Hep A cases. Any illicit drug use was 44, so that's like 73% of all the cases. Injection drug use is 56%. None of our travelers. 3 of the cases are food handlers. So I think I mentioned on the last slide, one of the groups we're trying to target is food handlers, not because they're specifically at risk because of this, but if they do get, but 2 reasons. One, if they do get Hep A, they put the rest of the population really at risk, especially if they're not following good hand hygiene practices, and so really trying to make sure they're vaccinated right now. Louisville, apparently before my time, I don't know if Dr. Steiner remembers, there's a huge Hep A outbreak in the 80s, I think.
That was his
Because of food.
opening salvo, for him.
Yeah, and I think they had over 600 cases, I think I heard, so really don't want that to happen. 48% are homeless. 2 of the cases are around people that are homeless. 4 of the cases are MSM. Are able to epilink 9 of them back to California. And 14 of the 60 were in corrections in the last 9 months, and that we use that 9-month marker because of the way hepatitis A is. We could kind of link it back. We want to look back in corrections for 9 months because they could have spread it there. And then jail ever is half of the people. All right, I went through that. Alright, so that's what the outbreak is in Louisville, what we're trying to do. I think the big thing is we're able to get ahead and prioritize the populations we were vaccinating to the people that are really high risk of complications, and then those that are hard to reach, using our staff to really focus on that. And I am optimistic that that's why we haven't had the death rate of California and Michigan. We're really trying to get those people that are at the highest risk. And it's been a huge success for us trying to get the whole health department involved. We're using the epi to kind of drive where we're vaccinating next, who's at high risk. So it's great public health experience right there. And I'm doing a lot of great partnering with community stakeholders to share information. Louisville's got a great homeless coalition that has been huge and really trying to vaccinate a large chunk of the homeless population. So it's been a great partnership, and can't thank them enough. And then, like I mentioned, the Vaccine for Children program's got a lot of requirements, and so just trying to work through that to get vaccine out as quickly as possible. And so because of that, that requirement that you have to be a VFC provider to actually give out this vaccine, we can't just take any volunteer who wants to come help. But we're able to get a legal opinion that if you are one of our Medical Reserve Corps volunteers, you have to go through a background check and a bunch of stuff. So you're kind of technically an employee of the health department, and so you would be kind of certified to do this to meet the requirements. So if any of you guys are interested in helping to vaccinate, if you have a nursing degree or medical degree and are able to give shots, or we need a ton of help with administration. One thing that's been huge with getting the syringe exchange population vaccinated is we have what we call greeters that catch people as they're going in or out of the syringe exchange and really do that warm, hey, there's an outbreak, please come get vaccinated, and then walk them to the TB clinic to get the vaccine. When we were just talking to them in the syringe exchange and telling them to go, most of them would just walk out the door if they didn't have that person catching them. And so you don't need any sort of background, just need a warm, friendly face to be that greeter. And then also people doing admin work to fill out the forms, etc. You don't need any sort of background for that either. Please help us get the information out about the outbreak. And every time I try to share stuff on social media, it doesn't get picked up. I talk about flu and it gets spread all over the place. So I think there's still, we've been intentional on not doing a lot of media about the Hep A outbreak because we're really trying to target those at-risk groups. And if we've seen in other states when they've done just broad media campaigns, they've gotten the wrong people vaccinated. A lot of the worried well or really want to get vaccinated, and they don't really reach the populations that they want to. And so that's why we've been working through partners to get the people that we want to get vaccinated, and let everyone else not worry because they're not at risk. But if you can help share the communication to the right people, that's helpful. And hand washing, always important, not just for hepatitis A. And then lots of information on our website if you want to know more. So the communication we send out to providers is here just for them to be aware about the outbreak and making sure they're testing it and keeping it in their differential. Information for the public of what hepatitis A is. This is what we're asking the providers to do. And more specific information about the post-exposure prophylaxis. So the Hep A vaccine is great for post-exposure, but then you can also do immune globulin for people that are really high risk and really sick in the emergency room. And then asking them to vaccinate. We've used our graphic designer to make great flyers that I think are really easy to read. And so if you guys are volunteering in the shelter, just want to get some information out, feel free to print these, pass them out. If they haven't been vaccinated yet and you think it's a good place for us to go, please let us know. And we'd be happy to start that planning and use you guys' help in doing that. So get vaccinated. Don't hang out with other people if you're sick. Wash your hands and talk to your doctor if you know someone who has Hep A, so you can also get vaccinated. Those are big points. Questions?
Yeah, I have a question. What a great presentation. It really represents a change in trends over, long periods of time from, my experience with foodborne illness, as a primary focus, to homeless and perhaps drugs. Because I'm old and stubborn, those, pathways, persist. And I'm wondering, if there's been special attention to food services, for homeless. Have you done increased inspections, of workers or foods there? And have you done anything different, to that little group of, foodborne illness, restaurant, food providers?
Yeah, so I guess just general information on one, majority of, in Kentucky, in fact, a lot of our food service workers, just in general, are illicit drug users or tend to be like homeless or living in shelters as well too. I mean, it's a great job. And so that was the other reason why we're trying to really vaccinate that population. But for the specific shelters and really all the restaurants, our environmental team has been fantastic. They have all this information, they're sharing it, they're getting the flyers posted in a lot of the shelters as well too. For example, we went out to Wayside to vaccinate. We noticed that the staff and people serving the food, like great hand washing, all that sanitary, but the people coming in where the restroom was, it wasn't really in line with how to get the food, and so the people eating weren't washing their hands before they ate, and so we just worked with them on how to change that flow, and so it would make it easier to use soap and water for hand washing before the population being served was able to eat. And so just working through little things like that
Okay.
really helped them. Is that?
This is a great teaching case, and our MS and PhD students are required to attend Epi Hour, but there are MPH students who are invited and probably argue. I don't know if there's any MPH student in the room. Is there a designated spokesperson available, or certainly you'd be invited too? But is there someone who would present do such a presentation in an evening course for the MPH students?
Yeah. Yes. Just let me know, and we'll get somebody there. We've got the whole EPI team, probably be appropriate, and our emergency preparedness team. We've got a couple MPHs. A lot of our staff have a master's degree, so I think any of them could teach.
For people who recover from hepatitis A, is there any risk for chronic effects like there is for hepatitis B and C?
That's a good question. Not that I am aware of. So I think most people, if you're healthy, you fully recover and are fine. So it's kind of like the flu. So if you're healthy, I think that's why it hasn't gotten a ton of attention. You're sick, you're fine. It's the complications and everything that goes along with it that can be deadly.
So when you're exposed to Hep A and then you clear it, does that infer any immunity?
Yeah, you're then immune.
Okay. My question had to do with records of vaccination.
Mm-hmm.
This is a very transient population you're working with who don't have good records. How are you coordinating whether or not someone was vaccinated?
So we are, every vaccine we get gets put into the Kentucky Immunization Registry. So now that we've been doing it for a while, people that are unsure or don't have the card that we gave them, we look them up before we give them the vaccine. We haven't had any duplicates yet, but I know California had that problem, so we're looking at it. But yeah, Kentucky was the last state to get an immunization registry, but we have one up and going now, so it's been very helpful in tracking all this.
People my age remember smallpox vaccine, but we weren't among those who had the privilege of being vaccinated for hepatitis A as children. So, this is stuff we all should know already, but refresh our memory. When did it become commonplace or mandatory for kids to be vaccinated? And sort of what's the cutoff of age where you assume somebody would have had it as a kid?
So Kentucky just this year is starting to require it. So I think assuming wise, I would say anyone, I don't think you can assume anyone's had it because this is the first year Kentucky's ever required it. Hep B was starting to get required in 1996, and so anyone under the age of 25, we are assuming has been vaccinated for Hep B. Anyone over than that, we're trying to give them, especially in the illicit drug use population, we're giving them Twinrix right now because even before we saw the Hep A, because of our addiction epidemic going on, we've been starting to see a slow increase in Hep B cases, and so I didn't want to put effort into this Hep A outbreak and then 4 months from now have a Hep B outbreak and have to do the same thing again. So anyone over 25, and we don't have records, we're vaccinating with Twinrix to cover for B as well. But no, I don't think you can assume anyone. But going back to the CDC guidelines, if you aren't in one of these high-risk groups, they still recommend that you don't need to be vaccinated. Where to go? So if you're in one of those categories, definitely recommend it. If you are working with any these high-risk populations, I would recommend that you get vaccinated. It's 100% covered with your insurance thanks to the Affordable Care Act. And so you just need to take your insurance card to Kroger or Walgreens or your primary care doctor to get vaccinated. It's one of the best vaccines we have out there. Really good effectiveness is one shot, and the side effects are really small compared to flu and Tdap. So I don't think it would hurt, but you don't have to. The studies that we have right now show that the 2 shots provide lifetime protection. So if you had it, you're good. So a lot of the vets have had it. If you've traveled, you've had it. But if you're not in any of those, you probably haven't.
You mentioned some issues with getting the vaccine from the CDC and requirements that they had put on that, instituting those kind of slow things down. Have you provided any feedback to them or suggestions about how you could accomplish what they want you to do and still make it easy to get up and running? Yeah, I've had a lot of conversations with the state, and then we're supposed to be talking to the CDC about it, and just trying to do what California has done. So that was one of the reasons why, corrections, it was taking forever to get them set up as their own site to do their own vaccinations. But we set them up as a satellite at the health department, which we were able to get them up and going faster. So just trying to find little ways to work around that has been helpful.
I think I saw only one site in the south or southwest on Dixie that you guys were vaccinating from. Are there plans to do additional sites now?
Depending on our epidemiology. So right now, majority of the cases are all downtown. So we haven't done a lot down there. And the addresses too that we have are people's home addresses, compared to where they're actually living. So that dark blue right there, majority of the cases are downtown, and then the Portland area. And so that's where we've been doing most of our shelter planning targets. But yes, we will, once we get, depending on the update, we will change our plans.
Yeah, have there been any discussions about plans for a possible future, you know, like maybe using hepatitis A vaccines in the syringe exchange program, or at Phoenix House for, you know, willing volunteers, you know, who, I mean, right now it's well contained, you know, but
Are you asking like if we're planning to vaccinate more than just the people in those populations?
Yeah.
So because it's covered by insurance, we're encouraging everyone who has insurance to go to Kroger or Walgreens to get it. And so most, if you don't have insurance, yeah, we will take it. You come in and walk in to get it. But anyone who's got other means, we're encouraging to go elsewhere because we don't have an unlimited supply. It's a very limited supply of vaccine, and so trying to target what we have to the high-risk groups that don't have other means.
So the hospitalization rate of 70+% seems really high. It's
Mhm.
really much higher than you normally expect. Do you know the reason why most of these folks are in the hospital?
I think because it's a viral illness and the populations that they're hitting are used to feeling sick. I mean, except for the jaundice, like that whole list of symptoms is what these people go through every day when they go through withdrawal. And so I think unless they're really bad, they're not even going to get tested. And so they wouldn't show up in their like primary care doctor. They might not even have access to get tested for it. And so most of the cases we catch in are from the hospital. So that's probably, that's just kind of like the icing on the sicker people who've had Hep A. We're suspecting there's a lot more people who've had it but haven't been sick enough to get tested. Kind of like the flu. The majority of our confirmed cases are all from the hospital. Though a lot of people here probably had it this year.
Speaking of the flu, are you making any effort to give flu vaccine to any of these folks who have not had it?
We have talked about it, but we don't have access to vaccine. So a lot of the shelters did their own flu campaigns, and so that's been helpful. So just trying to encourage that as well.
Are there any programs currently going on in the health department to raise awareness on Hep A? Because it might seem like more people might have more knowledge of like HIV and the flu compared to this. Or would it be something you would do after the outbreak? Because there are programs going on before.
We didn't have any specific programs about hepatitis A before. I think because there's not really any long-term effects, and it wasn't. We had like 1 or 2 cases a year of it, and so it wasn't a huge public health concern before the outbreak happened. We do have long-term programs kind of looking at hepatitis B and hepatitis C and getting people into treatment and preventing like mother-baby transmission. We don't have the same sort of risk with Hep A. My hope is now that all the kids are required to get vaccinated, and we're vaccinating a lot of the high-risk people. 20 years from now, we're not going to have another Hep A outbreak. So hopefully we won't have to worry about this. It'll be like the polio and the measles that we get vaccinated for and no one cares about, as long as we keep getting vaccinated.
So is there a reason why some organizations who are supposed to like partner organization are not giving a yes? Because I saw like Louisville Rescue Mission, they've had like 8 people go there.
This is the, I'm not sure. What are you looking at for the yes? So turnover, willing to host. Is that what you're saying?
Yes.
So I think all the ones that we're targeting next are willing to host, and we've reached out. The ones that are NA is because we've already been out there. Yeah. So the Louisville Rescue Mission is right next to the Phoenix Family Health. They're real close, and so we were able to assess that pretty much all of their patients have already gotten vaccinated through the Family Health Centers. Yeah, but they're on the list because yes, they've had a lot of cases. So we were keeping that in mind. So if they keep increasing, we'll need to go back and just make sure. Yeah.
Has there been any evolution of the risk profile over time? For example, first half of epidemic, second half of epidemic?
Yeah, so first half, a majority were homeless, which is why I think a lot of our initial efforts were in the homeless, and now almost all of them have been illicit drug use. Treatment centers are popping up more. So changing the target. Why we're going to Healing Place tomorrow. So yeah, it is evolving, or maybe people are knowing more and testing more. It's hard to tell.
Just overall nationally, when did vaccination first become available? It's been around for
90, someone would say? Anyone? I don't anyone else know?
10 years.
wasn't it early? Was it early 90s?
Maybe 92, I think. somewhere around there.
Mid-90s, I think, yeah.
Mhm.
That's taking that long for Kentucky, basically.
Yeah, to require it. So, I mean, I got it 20 years ago before I traveled. So I think it just, depending on your risk factors. So the CDC still doesn't recommend it for adults if you're not.
You said when was it, when did the requirement for school-age children?
School-age children, they added to the form this year. So August, you have to have 2 shots. By August, you have to have 2 shots. So if anybody's got school-age kids, they probably got a form sent home this month saying, make sure your kids got their first shot. But most kids, I mean, if they look at their immunization record from their pediatrician, most kids already had the shots, and so they just need to update the form.
Sarah, last fall in my risk communications course, our students developed risk communication for Hep A, mostly focused around food handlers. And we worked with Captain Harrison on some of that. We got some feedback on that.
Great.
So Victory's part of that group. If she could share with what they come up with.
Sure. Yeah, we've sent, I don't have a copy of it with us, but I'm not sure if maybe Kathy edited what you guys came up with, because we've sent communications out to all the food managers in the city. We have a list of over 8,000. That's gone out to twice now, and we sent another one yesterday just reminding them. So, let me know what you said.
Do any states or local health departments require Hep A vaccine for food service workers?
No, and the CDC doesn't recommend it either. So that was one thing Kentucky kind of toyed with, like, should we recommend it for all food handlers to try to get more people vaccinated? And the CDC actually said, no, we don't recommend that. It's not, the cost benefit's not worth it. The state was thinking that because a high percentage of our food handlers fit into those other groups, it'd be a way to reach them, but the CDC doesn't want to say that food handlers should be vaccinated, but still those other groups.
So sort of sticking on the food theme, if the hand sanitizer doesn't work, what are the recommendations for cleaning to get rid of the is it Clorox or?
I think I just pulled this up. It came up chlorine bleach. 1 2/3 cup bleach in a gallon of water.
Is this what being used at like the homeless shelters and stuff? Is that all disinfecting services?
That's what we're recommending. I don't know what they're actually using.
Yeah, it's rough because I mean, I've done a lot of work in hospitals, and disinfection is kind of my area of interest. And you know, when people dilute their own bleach, it's like, oh, it smells too strong. Let's put a little more water in it. Oh, it's been sitting here for 36 hours while it was working. That's a really tough one to manage. We can talk afterwards, but I might be able to work with some of the groups that I work with to get some better disinfectants for you guys.
We don't actually give it out. I know the downtown association is looking at spraying the streets with some sort of disinfectant spray to see if that would have a difference. I think studies show that it's not going to, but I guess when the outbreak was first announced, we got a lot of calls of people just really worried about people defecating on the street and their risk because of all that, and so there's some public fear around that, but it doesn't really, as long as you wash your hands, you're fine.
I have a question I've never considered or seen anything about before. Are animals part of the infection continuum? Do people with pets to get their animals vaccinated?
I don't know that.
Or
The
you're-
CDC list said that if you work with animals that have Hep A, that you should be vaccinated, but I don't know if you can pass it back and forth. I don't know.
I think you said like Twinrix it's administered over 2 doses or 3 doses?
Yeah, Twinrix is 3 doses, like now a month later, and I think 6 months after that. And the Hep A part of like 1 dose of Twinrix is over 90% effective, but the Hep B is only 30%. You need the other 2 shots to get you above 90, and so the Twinrix is great for the Hep A production. You need the other shots to get the B.
So compared to previous vaccines, like even majority of the population are homeless, so even if they miss the 2nd or 3rd dose, but like you're saying, like 98% like they're covered against.
Yeah. So we're really focusing on just getting 1 vaccination. So the U.S. I think is one of the only country that actually recommends 2. Some other countries just give 1 and they're done. So it's a question we get all the time. So where am I going to get my 2nd shot? And we say, well, follow up with your primary care provider or go back to the pharmacy. We're really just trying to get that first shot to people.
The CDC says unless you have non-human primates as pets or other inhabitants of your house, you don't need to worry about animal transmission.
Great. Thank you. There you go.
You had on one of your slides.
Okay. Other questions?
Are there any other cities in Kentucky that have a problem now based on transmission from the group here that's infected, or is there a problem across the river so far?
They've had sporadic cases. Majority in Kentucky are still in Louisville. And I think that has a lot to do with the movement of our people who use drug population. A lot of our cases are diagnosed in Louisville, and then they get sent to treatment centers outside of Louisville. So we've been doing a lot of communication back and forth and trying to follow up in like Bullitt and Hardin County, where a lot of the treatment centers are. So it's moving.
Have all been in
Yeah, there's a few cases over there. People that travel back and forth are hospitalized here, but actually are residents over there. But not. We still have majority of the cases. Yeah, Indiana hasn't declared an outbreak yet.
Other questions for Dr. Moyer?
Thank you.
Hey, can you fill the form? Let's put evaluation. And you can sign it if you put signing over there. Thank you.